Hello, I am studying today chronic renal failure and its anesthesia implications or anesthesia concerns in a patient of chronic renal failure. I will join you. Please be there with me so that I can also study, and if it can help you out, so that will be the best. The scenario is you are asked to anesthetize a 40-year-old patient with chronic renal failure on hemodialysis for repair of a recurrent left inguinal hernia. What anesthetic problems do these patients present? Basically, they are asking anesthetic implications or concerns of a CKD patients. Now, how will I start my giving my answer? Renal patients or CKD patients have multiple medical problems that impact on anesthesia. There are multiple medical problems that impact on anesthesia. These include anemia, coagulation disorders, and effect on cardiovascular system disorder and other body systems. ठीक है, anemia, coagulation disorders, effect on cardiovascular system and other body systems. They also have altered drug handling. Okay, first of all, we'll see how anemia occurs and what type of anemia it is normochromic, normocytic, UV, and the causes are multifactorial. It's iron deficiency, folate and B12 deficiency, and uremia causes erythropoietin, depression, and poor diet causes basically B12 and folate, iron deficiency, and also uremia reduces red cell lifespan. Inquire about symptoms associated with angina, like with anemia, like angina, and transfusion trigger is less than 5 gram per dl, or if symptoms present. Otherwise, low hemoglobin is okay. They are tolerated because the oxyhemoglobin curve is 50 to right. There is increase to 3 TPG and uremic acidosis. Blood transfusion has effects on autoimmunity, and so if these patients go through renal transplantation, that will affect the later on. And second effect is on blood clotting or coagulation factors. Patient with end-stage renal disease have abnormalities of platelet function due to alteration in arachidonic acid metabolism and increased NO production. Defective endothelial release of von Willebrand factor is thought to contribute and may be treated with cryoprecipitate and desmopressin intraoperatively. Defective endothelial release of von Willebrand factor. Okay, then bleeding time will be prolonged, maybe residual heparin effect from hemodialysis, or neuraxial blocks will be considered with caution, and iron injections may be unwise. Yeah, iron injections, neuraxial blocks, bleeding time will be prolonged, and there will be platelet dysfunction due to uremia causes endothelial defective endothelial release of von Willebrand factor and arachidonic acid metabolism or alteration in NO production, increased NO production, nitric oxide. Okay, then other effects on cardiovascular system. The patients are mostly hypertensive, and the laryngoscopy and stress induction response causes can exacerbate hypotensive effects. Then patients may be ischemic heart disease or CCF, and preoperative ECG, chest X-ray, echo is must for carotid bruise. Doppler studies may be necessary. Pericarditis, pericardial effusion rare with hemodialysis, and endocarditis if vascular size is infected, or vascular access. AV fistulas, forearm should be spared, and if AV fistula is there, that should be kept warm. IV line BP curve should be on the other hand. And on respiratory system, SOB can be pulmonary edema, fibrosis, infection. On nervous system, neuropathy or myopathy because of uremia, encephalopathy. Gastrointestinal system, delayed gastric emptying may cause aspiration reflux. Rapid sequence induction may be needed. Peptic ulceration or pre-medication with H2 antagonist will be needed. Endocrine hypocalcemia, hypermagnesemia, increased effect of potential relaxants. These patients may be diabetics, and potassium rises in renal failure, so sucks will be given cautiously. In renal system, ideal weight should be known, daily urine volume, CVP monitoring, on preoperative dialysis and post dialysis. Potassium should be measured, and fluid should be balanced intraop and post-operative, and urine output plus insensible loss is given. How is drug handling altered in renal failure? There may be decreased protein binding, decreased elimination, effect of uremia, and increased penetration of blood-brain barrier. With respect to commonly used drugs, thiopentone and benzodiazepines can be reduced due to reduced protein binding. Morphine carefully titrated as its metabolite glucuronide. Morphine 6 glucuronide is active and accumulates. Etraquirine is muscle relaxant of choice, and NSAIDs avoided, isoflurane safe, and fluorine avoided. And conduct how general anesthesia is conducted. Preoperatively, medical assessment will be done, dialysis, need of transfusion, pre-medication with antacid. Intraoperatively monitoring, which will include CVP, invasive A-line monitoring, vascular access. Induction is RSI or modified RSI. Attention to pressure response. Maintenance with IPPV, increase FiO2, N2O is safe, nitrous is safe. Attention to fluid balance. And post-operative, consider HDU or ICU, and oxygen should be mandatory. And these patients commonly go through peritoneal dialysis access, vascular access, fistula formation, nephrectomy, renal transplant, or parathyroidectomy.